Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Associate Professor in HOD, Department of Practice of Medicine and Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we have been discussing about the various diseases related to the alimentary tract. The diseases related to the thyroid hormone. In the last lecture, we have discussed about hypothyroidism and various disorders related to the hypothyroidism. In today's lecture, we are going to discuss about thyrotoxicosis and thyroiditis. So first of all, let's discuss about the thyrotoxicosis, the clinical features, investigation, and management. So thyrotoxicosis is a state in which there is thyroid hormone excess. The etiology of thyrotoxicosis, hyperthyroidism, is caused by Graves' disease, toxic multinodular goiter, and toxic adenomas. The primary hyperthyroidism, there can be three varieties of hyperthyroidism. There can be primary hyperthyroidism, thyrotoxicosis without hyperthyroidism, and secondary hyperthyroidism. Now, the primary hyperthyroidism constitutes of the Graves' disease. There is toxic multinodular goiter, toxic adenoma, struma ovri, and various drugs, which includes the iodine axis, like jod-based phenomenon. Thyrotoxicosis without hyperthyroidism, which includes subacute thyroiditis, silent thyroiditis, and other causes of thyroid destruction, like radiation, infarction of adenomas. There is ingestion of the excess thyroid hormone, which include thyrotoxicosis factitis and thyroid tissue. The secondary hyperthyroidism consists of TSH-secreting pituitary adenoma, thyroid hormone resistance syndrome. Occasional patients may have features of thyrotoxicosis. There is chorionic gonadotropin-secreting hormones and gestational thyrotoxicosis. Now let's discuss about the clinical features of thyrotoxicosis. The symptoms of thyrotoxicosis are opposite to that we have discussed about hypothyroidism. The symptoms includes hyperactivity, irritability, and dysphoria. There is heat intolerance and sweating with palpitation, fatigue, and weakness. The patient complains of weight loss and increasing appetite. There is diarrhea, polyuria, oligomenorrhea, and loss of libido. The clinical features signs includes tachycardia with atrial fibrillation in the elderly, tremors, goiter, warm and moist skin. There is muscle weakness, proximal myopathy, and lid retraction or lid drag with gynecomastia. The Graves' disease. Let's discuss about Graves' disease. Graves' disease, in case of thyrotoxicosis, accounts for about 60 to 80% of the thyrotoxicosis. The prevalence varies among the population, reflecting genetic factors and iodine intake. It occurs in up to 2% of the women, but 1/10 as frequent in men. Age occurs between 20 to 50 years of age. Predisposing factors includes environmental and genetic factors, stress, smoking, sudden increase in the iodine intake, and postpartum period. The pathogenesis of the Graves' disease includes the hyperthyroidism of the Graves' disease is caused by thyroid-stimulating immunoglobulin that are synthesized in the thyroid gland as well as in the bone marrow and lymph nodes. In the long term, spontaneous autoimmune hypothyroidism may develop in up to 15% of the cases with Graves' disease. Now we come to the Graves' ophthalmopathy. The reason of the Graves' ophthalmopathy is the cytokinins. They appear to play a major role in thyroid-associated ophthalmopathy. There is infiltration of the extraocular muscles by activated T cells. The release of cytokinins results in fibroblast activation and increased synthesis of the glycosaminoglycans that traps the water and thereby leading to the characteristic muscle swelling. Late in the disease, there is irreversible fibrosis of the muscles. There is increase in the intraorbital pressure that can lead to proptosis, diplopia, and optic neuropathy. Now we come to the clinical manifestation of the Graves' disease. The clinical presentation depends upon the severity of thyrotoxicosis, the duration of the disease, the individual's susceptibility to excess thyroid hormone, and the patient's age. The apathetic thyrotoxicosis occurs in the elderly, presents mainly with the fatigue and weight loss. The thyroid is usually diffusely enlarged to 2 or 3 times the normal size. The consistency is firm but not nodular. There may be a thrill or bruit, the best detected at the inferolateral margins of the thyroid lobes due to the increased vascularity of the thyroid gland and hyperdynamic circulation. Now let's discuss about Graves' ophthalmopathy. In Graves' ophthalmopathy, there is sensation of grittiness or discomfort in the eyes and excess of tearing, means excess of tear formation. There is proptosis, that is drooping of the eyelid, that may cause corneal exposure and damage. Proptosis means protrusion of the eyes, especially when the lid fails to close during sleep. There is periorbital edema. The scleral injection and chemosis are also frequent. There is muscle swelling that results in diplopia. Most serious manifestation is the compression of the optic nerve. There is a classification no-specs scoring system to evaluate the ophthalmopathy, where the 0 stand for no sign of or symptom of ophthalmopathy, 1 stand for only signs with lid retraction and lid lag with no symptoms, 2 stand for soft tissue involvement with periorbital edema, 3 stand for proptosis greater than 22 millimeter, 4 stands for extraocular muscle involvement like diplopia, 5 stand for corneal involvement, and 6 counts for sight loss. Now, thyroid dermopathy. There is thyroid dermopathy, which includes pretibial myxedema, are the most frequent over the anterior and the lateral aspect of the lower leg. The typical lesion is a non-inflamed indurated plaque with a deep pink purple color or an orange skin appearance. Thyroid arcopathy, that is clubbing of finger, that is seen in less than 1% of the cases. Now, lab evaluation of thyrotoxicosis. The TSH levels are suppressed and the total and unbound thyroid hormone levels are increased. The measurement of TPO antibodies has to be done. The diagnosis of Graves' disease is a straightforward in patients with biochemically confirmed thyrotoxicosis, diffuse goiter on palpation, ophthalmopathy, and often a personal or a family history of autoimmune disorders. The diagnosis is generally established by radionucleotide technetium-99, iodine-123 or iodine-131 scan, and uptake of thyroid hormone. Scintigraphy is preferred a diagnostic test. Now, the differential diagnosis of hyperthyroidism. In secondary hyperthyroidism, due to the TSH secreting pituitary tumor, there is also a diffuse goiter. The presence of non-suppressed TSH levels and the findings of the pituitary tumor on CT and MRI suggest the diagnosis. The clinical features of thyrotoxicosis can mimic certain aspects of other disorders, including the panic attacks, mania, pheochromocytoma, and the weight loss associated with malignancy. The diagnosis of thyrotoxicosis can be easily excluded if the TSH and unbound T3, T4 levels are normal. A normal TSH also excludes Graves' disease as a cause of diffuse goiter. Now, what is the treatment for thyrotoxicosis? The hyperthyroidism of Graves' disease is treated by, number 1, reducing the thyroid hormone synthesis using antithyroid drugs, and second, reducing the amount of thyroid tissue with radioiodine, iodine-131 treatment, or by thyroidectomy. So this was all about thyrotoxicosis. In the next lecture, we will be discussing about thyroiditis. So I hope you must have understood the session clearly. If you have any problem, you can write in the comment box. All of this matter is present in my PPT that I have shared with you on the portal. So this was all for today. We will be meeting with thyroiditis in the next lecture. So thank you very much. Have a good day.